2000, 21 NCAA football players have died during conditioning workouts. 75% of these fatalities were Division I players. The three most common causes of the fatalities were exertional sickling and sickle cell trait, exertional heat stroke, and cardiac conditions. Sickle cell trait is the inheritance of one gene for sickle hemoglobin and one for normal hemoglobin. It affects 1 in 12 African Americans and people from areas where malaria is widespread.
Reduced workout. Red blood cells deliver oxygen to the body's tissues through the circulatory system. The cells are disc-shaped and flexible and can squeeze into small capillaries. During regulated physical exercise, the red blood cells in an athlete with sickle cell trait can deliver oxygen normally. Under stress from intense physical exertion, the red blood cells in an athlete with sickle cell trait can no longer hold on to oxygen. These blood cells change from their flexible disc shape to a rigid sickle shape. This is called exertional sickling. These abnormal cells can get trapped in small capillaries, blocking healthy blood cells from bringing oxygen to the body's muscles and tissues. This is called a crisis. During a crisis, the athlete can have muscle cramping, pain, swelling, weakness, inability to catch their breath, and fatigue. If pushed past the point of crisis, lack of oxygen can break down muscle tissue, causing harmful proteins to flood into the bloodstream and leading to severe kidney damage. When combined with environmental factors such as heat stress, dehydration, illness, and altitude, even death can occur. It is important to recognize
Exertional heat stroke is a severe illness characterized by the disruption of the central nervous system and elevated core temperature of at least 104 degrees Fahrenheit. This may happen when the athletes engage in unregulated high-intensity conditioning sessions with increasing environmental heat. Athletes could aggravate their cardiac conditions with unregulated high-intensity exercise and go into ventricular fibrillation. Ventricular fibrillation is an abnormal heart rhythm that can be life-threatening. Even though there are many cardiac conditions with their own specific pathophysiology, the most prevalent are hypertrophic cardiomyopathy, coronary artery anomalies, and commotio cordis.
Treatment for sickle cell trait. Check vital signs, administer high-flow oxygen 15 liters per minute with non-breather mask. Cool athlete if necessary. If vital signs decline, call 911, attach AED, and quickly transport the athlete to the hospital. Appropriate medical personnel should start an IV. The AT should inform treating physicians of the athlete's trait status so that they are prepared to treat explosive rhabdomyolysis and associated metabolic. Proactively prepared by having an EAP and appropriate energy equipment available.
Crisis occurs. When the athlete is allowed to rest between exercises, the sickled red cells regain oxygen inside the lungs and return to their normal shape. High-flow oxygen helps the athlete's red cells recover faster. With enough oxygen, the athlete feels better and, in most cases, is ready to return to play.
Treatment for exertional heat stroke. Lower the athlete's body temperature to 102 degrees Fahrenheit or less within 30 minutes of collapse. Cold water immersion is the most effective cooling modality for patients with exertional heat stroke. Treatment for sudden cardiac arrest. Early detection, promptly administering CPR, rapid activation of VMS, early defibrillation are vital to the athlete's survival.
Rule changes enacted in 2003 related to heat acclimatization procedures during August football practices have been extremely effective. However, conditioning workouts continue to be catalysts for catastrophic outcomes. It is imperative that similar guidelines be implemented to improve the safety of conditioning sessions. The Task Force Consensus Statement provides the following specific conditioning recommendations,
which are intended to prevent conditioning-related injuries
and deaths of collegiate athletes.
Number 1. Acclimatize progressively for utmost safety.
The first 4 to 10 days of any new conditioning cycle are referred to as the transitional periods. A written, progressive program of increasing volume, intensity, mode, and duration should be instituted during this time.
During the transitional period, a 1-to-4 work-to-rest ratio should be established. It's a good starting place to emphasize recovery. A qualified strength and conditioning coach should work cooperatively with medical staff, including athletic trainers and team physicians, or both, when developing these plans. Number 2. Introducing new conditioning activities gradually.
Any new exercise introduced into a strength and conditioning program should be added in a deliberate, gradual fashion by a qualified strength and conditioning coach. This guideline is true for any aspect of the regimen, but is particularly important during the early stages of a conditioning program.
Number 3. Do not use exercise as a punishment. Physical activity should not be used as retribution for coercion or a discipline for unsatisfactory athletic or academic performance or unacceptable behavior. No additional physical burden that would increase the risk of injury or sudden death should be placed on the athlete under any circumstances. Number 4. Strength and conditioning coaches require proper education, experience, and credentialing.
All strength and conditioning coaches must obtain an undergraduate degree to sit for the examination and become credentialed. In addition, they should have the adequate mentoring and experience to independently design and implement individual and team conditioning programs. Finally, all strength and conditioning coaches should be required to pass a certification examination by an independent accreditation agency.
Number 5. Provide appropriate medical coverage. A strength and conditioning coach should be present during all strength and conditioning sessions. Strength and conditioning coaches should also be prepared to provide first aid as soon as an athlete shows signs of distress. An athletic trainer or team physician should also be present during each high-risk collegiate conditioning sessions. For lower-risk conditioning sessions and strength portion of a conditioning program, a strength and conditioning coach should be present and an athletic trainer should be on campus and accessible to assist if problems arise. Number 6. Develop and practice emergency action plans.
Strength and conditioning venues should have emergency action plans, or EAPs, specific to the venue, sport, and circumstances. The EAP should be developed by the sports medicine staff with the input of all concerned parties, approved by the head team physician, and most importantly, reviewed and rehearsed at least annually by all staff involved. A conditioning session should not take place if those supervising the session are not familiar with the EAP.
Number 7. Be cognizant of medical conditions.
The most prevalent medical conditions associated with sudden death during collegiate strength and conditioning sessions are atraumatic cardiac conditions, exertional collapse associated with sickle cell trait, exertional heat stroke, and asthma. Institutional, governing, and credentialing agencies for strength and conditioning coaches coaches, and sports medicine professionals should require ongoing continuing education covering these major health concerns.
Number 8, administering strength and conditioning programs.
Strength and conditioning coaches and sports medicine team members should work closely, cooperatively, and have open lines of communication. They should be a part of an administration in order to make sure all safety measures are taken into consideration. At the beginning of each semester and training season, all strength and conditioning coaches and sports medicine staff members should hold meetings and discuss health and safety concerns of at-risk athletes, including the parameters of medical information shared and updates of sudden death risk.
Number 9, partnership with recognized professional organizations.
The key organizations responsible for athlete safety during strength and conditioning sessions should formalize a partnership to periodically review these best practices. These organizations should include relevant athletic, coaching, sports medicine, and strength conditioning organizations.
Number 10, require adequate continuing education for the entire coaching and medical staff.
The task force strongly recommends that key professionals, including strength and conditioning coaches, sport coaches, athletic trainers, and team physicians, adopt requirements for educating and training and require individuals to demonstrate knowledge in the area of preventing sudden death in sport.